the ventricular mass, and the arterial trunks. And so this is our starting point, the three cardiac segments. And as I explained to you last time, we had no intention of creating the schism that seems to have established between the way Richard initially explained the system and the way we turned it into sequential segmental analysis. But what we were trying to do when we began to use this system in the early 1970s was not only look at the segments, but to take note of the junctions between them. The atrioventricular junction, the ventricular arterial junction. So we emphasized not only the segments, but also the connections between them. And this was where we began to get into some difficulties between the systems, as we discussed in our previous session. So what we're going to do today is to move on, and we're going to look specifically at the atrioventricular junctions. But before we can start on the atrioventricular junctions, we need to know what's happening at the atrial level. And another potential difference between the systems was whether we could describe the heart in terms of the thoracic and abdominal organs. And that is usually the case, but it's not always the case because the associations are insufficiently constant. So we were not entirely happy to talk about the heart in terms of the spleen, which was the concept when we first began. And it was our belief that it was better to analyze the hearts by starting with the appendages. And you will recall we discussed that last time, and we emphasized that when we take as our arbitrating feature the pectinated wall of the atrial chambers, which is the appendage, then in the usual arrangement, the pectinated wall extends all the way around the vestibule of the atrioventricular junction, reaching to the crux, whereas on the left side, there is a smooth vestibule, and this is the usual arrangement. And we showed you that in some circumstances, the arrangement could be mirror imaged so that the pectinated wall came to the crux on the left side, telling us that the morphologically right atrium was left-sided, whereas the smooth vestibule was on the right side. And we pointed out that in so-called visceral heterotaxy, when we concentrated on the atrial appendages, we could divide that group of lesions into right isomerism, the pectinated walls coming to the crux on both sides, left isomerism, when there was a smooth vestibule moving towards the crux on both sides. And this is our starting point now for sequential segmental analysis. But we do take note that almost always the appendages are congruent with your organs. So that reinforces the fact that there are these four basic arrangements. Usual arrangement, many of you still call this situs solitus. As you know, we prefer to consider it as being usual. Many of you talk of situs inversus. We would much rather describe that as mirror imagery. And then the particular approach taken in sequential segmental analysis, we divide visceral heterotaxy into the two subsets of right isomerism, usually but not always associated with absence of the spleen, left isomerism, usually but not always associated with multiple spleens. And we know that these associations are not always present, but when exceptions occur, we simply describe each system in isolation. And this is important because the simple fact that disharmony can occur between the systems does not detract from the fact that we begin our analysis with the arrangement of the atrial appendages, and then we describe any deviations from what we expect to find. So let's summarize again what you expect to find when you have lateralized bodily arrangement. When you look at the lungs and the bronchuses, we know that the right-sided lung has 3 lobes, is fed by a short bronchus. The morphologically left lung on the left side has 2 lobes, is fed by a long bronchus. And almost always that is associated with right-sided liver, left-sided stomach and spleen. Again, in this setting, almost without exception, we find usual arrangement of the atrial appendages, and in most instances, this goes with the expected veno-atrial connections, and this is the usual arrangement. And so the mirror-imaged arrangement is found when the long bronchus feeding a bilobed lung is on the right side, telling us it is morphologically left. The trilobed lung with a short bronchus is on the left side, telling us it is morphologically right. And then, as we expect, the liver now is going to be left-sided, stomach and spleen will be right-sided, and there will be mirror imagery of the atrial appendages, almost without exception, with mirror imagery of the venous returns. So this is what we call the mirror-imaged arrangement. And then, just to reinforce the fact, in so-called heterotaxy, when we look at the thoracic organs, we can find that there is the isomeric arrangement. So in half of the subset, we find 2 trilobes lungs with 2 short bronchuses, telling us that this is right isomerism, typically with a midline liver, malrotated gut, and in most instances, absence of the spleen, but we, on the basis of the pectinate muscles within the atrial appendages, will call this right isomerism. And the other half of visceral heterotaxy is when both lungs are bilobed with long bronchuses, pointing to an isomeric left arrangement. Again, a midline liver, but this time with multiple spleens, along with malrotation of the gut. But now we will anticipate finding smooth vestibules on both sides, telling us that we are dealing with left isomerism. So this is our starting point for analysis of the ventriculo-arterial junctions. And when we look at the ventriculo-arterial junctions, we then have to get across another of the major differences that emerge between our systems, whether the segments connect one to the other or whether they are aligned. Now, it remains our belief that it is correct to describe the cavities as being connected. If we're going to use alignment, we'd prefer to look at that in terms of the septums. But as we're also going to emphasize on occasion, the cavities can be aligned, but are not necessarily connected. And it is for that reason that we do not think that it is justifiable to use alignments as being the same thing as connections. So let's look at the potential problem. Here is a 4-chamber cut across the normal atrioventricular junctions, and I've labeled the cavities. And there in the white arrows, I'm showing you the atrioventricular junctions. And when we look at the relationships of the cavities across the atrioventricular junctions, I don't think anybody is going to deny anymore that the atrial cavities are connected to the ventricular cavities. And if we're looking for alignment, we see that the base of the atrial septum is aligned with the crest of the muscular ventricular septum. So this is the essence of atrioventricular connections. It is the cavities that are connecting one with the other. It is the way that the atrial musculature joins to the ventricular mass that determines those connections. And that's what we're going to emphasize very shortly. But we also need to take note of the nature of the valves that guard those junctions. And this is another essential part of our own sequential analysis, because the nature of those valves can modify the type of connection, but without necessarily changing it. So let's look at the most obvious pattern. And that is what we find when we have usual arrangement of the atrial appendages. So there you see the pectinated wall going to the crux on the right side, smooth vestibule on the left side. And in this setting, almost always, the morphologically right atrium is connected to the morphologically right ventricle, the morphologically left atrium to the morphologically left ventricle. And when we look at the arrangement of the ventricles within the ventricular mass, as we described to you that last time, this is what we call right-handed ventricular topology. We can have the same situation, however, when we have mirror-imaged atrial arrangement, and then because the ventricles are also mirror-imaged, we have left-handed ventricular topology. Now, what we also emphasized last time is this is what we now call concordant atrioventricular connections. We do not use anymore the term atrioventricular concordance, because that, for Van Praagh, Dr. Van Praagh, was segmental harmony. And we're not talking about segmental harmony, although almost always when we have concordant atrioventricular connections, there is segmental harmony. But we are emphasizing here the fact that the atrial chambers connect across the atrioventricular junctions with their appropriate ventricles. And so this is concordant atrioventricular connections.
This is a four-chamber view of a normal heart that will demonstrate concordant atrioventricular connections, so that our atrial cavities are connected to the ventricular cavities and are also aligned with one another. The septums are also in alignment, so that the atrial septum here is in direct alignment with the ventricular septum. This is our morphologically right atrium with its pectinate muscles, and there's the terminal crest. And you can see that the atrial musculature is in direct communication or direct connection with the ventricular mass or the muscular wall of the right ventricle. And here's our smooth vestibule of our morphologically left atrium, and the atrial musculature of the left atrium is in direct communication with the ventricular mass or the muscular wall of the left ventricle.
We then need to remember again that when we have those atrioventricular junctions connected together in concordant fashion, the valves guarding those junctions can vary. Almost always, as you've just seen, there will be two valves, but we must then take account that those concordant atrioventricular connections can on occasion be guarded by a common valve, and in some instances, they can be guarded by one of the valves, which is imperforate. And so now we're going to look at this modification of the types of connections to emphasize that those changes in the valves do not change the type of connection. And that is what Diane will now illustrate to you.
Here we're looking at the inferior aspect of two hearts that have been cut in four-chamber plane, one of which has a common atrioventricular junction and the other an imperforate tricuspid valve and a patent mitral valve. The important point to make here is that the nature of the valves guarding the atrioventricular junctions modifies the type of connection, but does not change the fact that there are concordant atrioventricular connections. So that here we see the musculature of this morphologically right atrium connected to the musculature of the morphologically right ventricle, and the musculature of the morphologically left atrium connected to the musculature of the morphologically left ventricle. So that we have concordant atrioventricular connections, and there are biventricular connections, but with a common atrioventricular valve. Also, you can see that the atrial septum is in alignment with the ventricular septum. This specimen also shows us concordant atrioventricular connections, so that the musculature of this morphologically right atrium is still joined in direct fashion with the musculature of this hypoplastic right ventricle, and the musculature of this morphologically left atrium is joined with the musculature of the larger morphologically left ventricle. The septums are also in alignment. the point to make here is that this imperforate valve prevents the egress of blood from the right atrium to the right ventricle, but there is still a potential for connection. So again, concordant atrioventricular connections.
So we've looked at the situation in which we have concordant atrioventricular connections. But you all know very well that that is not always present when we have usual atrial arrangement. Because in certain circumstances, there can be left-handed ventricular topology when we have usual atrial arrangement. And almost always that means that the atrial chambers then connect in discordant fashion to the underlying ventricles. You're seeing on your left hand the situation with usual atrial arrangement. You know that the same thing can happen with mirror-imaged atrial arrangement, but when the atrial chambers connect to morphologically inappropriate ventricles in the setting of mirror-imaged atrial arrangement, the ventricular mass is in its anticipated fashion with right-handed topology. But it is the connection of the atriums to their inappropriate ventricles that underscores this arrangement, which we call discordant atrioventricular connections. And Diane now will illustrate discordant connections to you in the setting of usual atrial arrangement. We don't have an example with mirror-imaged atrial arrangement, but it can occur.
This specimen has usual atrial arrangement with a morphologically right atrium to the right, with our roughly triangular tip and the broad junction with the venous component, and a tubular appendage with a narrow junction to the atrial vestibule on the left. When we look at the atrioventricular connections, we can see the pectinate muscles within this right-sided morphologically right atrium, and its musculature is joined with the musculature of a right-sided morphologically left ventricle. In the inlet, there's a mitral valve that is supported by two papillary muscle groups, and there are no attachments of that atrioventricular valve to the interventricular septum. Our ventricle exhibits fine crisscrossing apical trabeculations and a smooth septal surface as we extend to the outlet. Within the outlet is the pulmonary valve and the pulmonary trunk bifurcating into the left and right main pulmonary arteries. So on the right side of the heart, we have discordant atrioventricular connections and discordant ventriculo-arterial connections. On the left, we have our morphologically left atrial appendage. It's tubular with the narrow junction to the atrial vestibule, and the pulmonary veins enter its roof. There's the left side of the atrial septum and the smooth vestibule. So this morphologically left atrium is on the left side, and you can see that its musculature is joined with a morphologically right ventricle on the left. So here are coarse apical trabeculations, and the tricuspid valve lies within the inlet. There are both attachments to the septum and to papillary muscles. This tricuspid valve also has an epsteinoid malformation. The aorta arises from this left-sided morphologically right ventricle and is supported by a complete muscular infundibulum, so that on the left we have discordant atrioventricular and discordant ventriculo-arterial connections. I'll also mention that this left-sided morphologically right ventricle will only allow the palm of my left hand to lie on its septal surface with my thumb in the inlet and my fingers in the outlet. So there's left hand ventricular topology.
So what we've described to you thus far are concordant or discordant atrioventricular connections, and they are biventricular atrioventricular connections. Now I'm showing you here two images showing you, I hope you recognize now, isomeric right atrial appendages. Why am I showing you a right-handed image and a left-handed image? Because if we have isomeric right atrial appendages, then if each atrium is connected to its own ventricle, it doesn't matter whether you have right-handed ventricular topology or whether you have left-handed ventricular topology. Because in the setting of isomeric appendages, and I've been showing you here isomeric right appendages, it could equally well be isomeric left appendages. When we have isomeric appendages, and when each atrium is connected to its own ventricle, half of the heart will be concordantly connected, and half of the heart will be discordantly connected. And so that is why in the setting of isomeric appendages with biventricular atrioventricular connections, those biventricular connections are mixed. And in this setting, we must not only describe the type of isomerism, but also the ventricular topology. So I've already emphasized that when we have concordant or discordant atrioventricular connections, it's exceedingly rare to find segmental disharmony. So hardly ever do we have to describe the ventricular topology in that setting. But what you have now seen is that when we have biventricular connections in the setting of isomeric appendages, always we need to describe the ventricular topology. So that's what you're going to see now. Diane is going to demonstrate to you the importance of explaining and describing ventricular topology in the setting of isomeric atrial appendages.
This is a specimen that has isomerism of the right atrial appendages, and we're looking at the base of the heart, and this was a cardiac explant, so the majority of the structures at the base have been cut away. You can still appreciate that there were roughly triangular tips to both of the atrial appendages and that there were pectinate muscles surrounding the entire atrioventricular junction, so around both atrial vestibules and to the crooks of the heart. The right-sided morphologically right atrium is connected to a right-sided morphologically right ventricle, and the left-sided morphologically right atrium is connected to a left-sided morphologically left ventricle. And you'll see that there is a common atrioventricular junction, and this heart has biventricular and mixed connections. The right atrioventricular junction hasn't been cut across, but you can see that the atrial musculature is clearly joined with the ventricular musculature. So here's the interventricular septum, and on the left I have cut across the inlet, and you can see that the left-sided atrial musculature is clearly joined with the left-sided ventricular mass. There's our morphologically left ventricle and our common atrioventricular junction from the left side with this very dysplastic common atrioventricular valve. The apex of this heart did point to the left, and when we look within this right-sided morphologically right ventricle, the inlet hasn't been cut across, but you can see my probe extending into the inlet. This specimen has a double outlet from the right ventricle, so this is the aorta, and this is the stenotic pulmonary trunk. There's the outlet septum, and this double outlet right ventricle exhibits the phenotypic features of tetralogy of Fallot. The last point I want to make is that this specimen has right-hand ventricular topology. So you can see my probe in the inlet. So if I put my thumb in the inlet and my fingers in the outlet, only the palm of my right hand can lie on the septum of this right-sided morphologically right ventricle. This specimen has isomerism of the left atrial appendages. The apex is pointing to the right, and the aorta and pulmonary trunk are spiraling from the ventricular mass in mirror-imaged fashion. This left-sided atrial appendage is tubular with a narrow junction to the atrial vestibule, and the right-sided atrial appendage is also tubular with a narrow junction to the atrial vestibule. So bilateral, morphologically left atrial appendages. This specimen has biventricular and mixed atrioventricular connections, and at the atrioventricular junction there is a common atrioventricular valve with this left-sided component, the dominant side, and there is the right-sided component that is hypoplastic. Here we see the musculature of this left-sided morphologically left atrium joined directly with the musculature of this left-sided morphologically right ventricle. And it's the same on the right side. I don't have the atrioventricular junction cut across, but here is the atrial vestibule, or the musculature of the atrium, joined directly with that right-sided morphologically left ventricle. The other point that I need to make is that this specimen exhibits left-hand ventricular topology, so that only the palm of my left hand can be placed on the interventricular septum with my thumb in the inlet and my fingers in the outlet. So left-handed ventricular topology in a heart with isomerism of the left atrial appendages and biventricular and mixed connections.
So now we've taken care of the greater majority of the hearts you're going to encounter in the setting of congenital cardiac disease. And those hearts we've looked at thus far are unified because each atrium is connected to its own ventricle. So these are biventricular atrioventricular connections. But we have a whole new set of connections of which we must take account before we can say we are taking care of all congenitally malformed hearts. And those are the minority of hearts in which the atrial chambers connect to only one ventricle. And it is correct to describe these as having univentricular atrioventricular connections. But this group has also been contentious in the past because for the larger part of my career, patients fitting into this subset have been considered to have univentricular hearts. And as you know now, very few of these patients indeed have univentricular hearts. They are unified because they have the univentricular atrioventricular connection. So what are the connections that underscore the univentricular atrioventricular connection? Well, the most obvious is double inlet ventricle, but as we're going to show you, same situation can be produced when there is absence of the right atrioventricular connection or absence of the left atrioventricular connection. In the setting of the univentricular atrioventricular connection, however, we always need to take account also of ventricular morphology. Because what we're going to show you is that in each of these settings, the ventricular morphology can vary, although we're going to concentrate on double inlet ventricle. So there can be a dominant left ventricle, and then as we will show you, the right ventricle will be incomplete and hypoplastic. There can be a dominant right ventricle. This time it is the left ventricle that will be incomplete and hypoplastic. Exceedingly rarely, there can be solitary and indeterminate ventricles, so we're going to show you an example of the true single ventricle. But let's begin by looking at double inlet ventricle, because this is the classical form of univentricular atrioventricular connection. It's the type that produced so much controversy in the past, but hopefully that has now passed away, because now we can show that the essence of this lesion is that both atrial chambers are connected to the same ventricle, and it's exceedingly rare to find this when there is a true solitary ventricle. So most often we see this in the setting of double inlet left ventricle. And nowadays you see this all the time on the basis of computed tomography. And there can now be no question but that there are two ventricles present. And the big ventricle in this example is the dominant left ventricle. The small ventricle is the right ventricle, morphologically right, which is incomplete because it lacks its inlet component. In this example, as is usually the case, the incomplete right ventricle is giving rise to the aorta. Another highly contentious topic has been the nature of the chamber between the two ventricles, but once we accept that both of the chambers are ventricles, albeit that one is incomplete, we can simply describe that channel as the ventricular septal defect. But let's look at this in a little more detail, because when we have double inlet left ventricle, again, the valves guarding the junction can modify the type of connection. So we can have two valves, we can have a common valve. We also know that the incomplete right ventricle can be left-sided, which is usually the case, but can be right-sided. We know that in most instances, it is found when the ventricular arterial connections are discordant or transposition, but we can also find it with concordant connections, the Holmes heart, or with double outlet from either the incomplete ventricle or the dominant ventricle.
Double inlet left ventricle is the classical form of univentricular atrioventricular connection. Typically, there is a dominant left ventricle with a rudimentary and incomplete right ventricle that lies on the anterior superior aspect of the ventricular mass or on the shoulder of the heart. Usually, these patients have discordant ventriculo-arterial connections, and here we can see a coronary and another coronary arising from the aortic root, which lies within the outlet of this incomplete and rudimentary right ventricle. Also, the aortic root is supported by a complete muscular infundibulum. These specimens typically have a ventricular septal defect. If we look at the dominant left ventricle, here we can see both atriums connected to this dominant left ventricle, demonstrating the univentricular atrioventricular connection, so that the morphologically right atrium and the morphologically left atrium both have their muscular walls in direct communication with the muscular wall of this dominant left ventricle. So here is the right atrioventricular valve, and here is the left atrioventricular valve. If we look at the opposite aspect of the specimen, again, the morphologically right atrium connected to this dominant left ventricle through the right atrioventricular valve, and the morphologically left atrium also connected to this dominant left ventricle. There is the ventricular septal defect, which allows blood to go into the rudimentary and incomplete right ventricle and out the aorta. Tilting this specimen up will allow us to see the left ventricular outflow tract, which supports the pulmonary trunk. Here I have another specimen with a univentricular atrioventricular connection, or a double inlet left ventricle. The apex of this specimen is pointing to the right, and it also has isomerism of the right atrial appendages. So our left-sided morphologically right appendage is seen here, and then the right-sided morphologically right atrial appendage is here. Both of the atriums connect to this dominant left ventricle, and here is the channel between the ventricles, or the ventricular septal defect. The incomplete and rudimentary right ventricle is posterior inferior in this case, or in the hip pocket of the ventricular mass. As is typical, the aorta does arise from this incomplete and rudimentary right ventricle. The univentricular atrioventricular connection in this case is through a common atrioventricular valve, and there you can see that zone of apposition pointing directly at the interventricular septum. So this specimen has the musculature of both atriums connected to the ventricular mass of the dominant left ventricle, exhibiting univentricular atrioventricular connections.
So what you've seen there was double inlet left ventricle. But we have to remember that in a minority of cases, when we have double inlet, it is the right ventricle that is the dominant ventricle. And although that can be found with two valves, as I'm going to show you very shortly, almost always it has a common valve. Almost always, as I'm going to show you, the left ventricle is left-sided postero-inferior. It can be right-sided. And in most instances, we have double outlet from the dominant ventricle, but there can be concordant or discordant connections, but they are very rare. So here is a picture example of double outlet right ventricle, and you'll recognize that the apical trabeculations are very coarse, and here unequivocally, right AV valve, left atrioventricular valve are draining to this dominant right ventricle. How do we know it is a right ventricle? Because when we turn the heart round, we look at it at the back, postero-inferiorly, we find this incomplete hypoplastic left ventricle. In this instance, with one papillary muscle of the mitral valve remaining, because as we're also going to discuss, although we won't have time to show you, we can find this with straddling valves. So here is an example with two AV valves. Most usually, however, there is a common atrioventricular valve, and that's now what Diane is going to demonstrate to you.
This specimen is a cardiac explant, and it has been cut to show the four-chamber echocardiographic simulation. And there is a dominant right ventricle with a common atrioventricular junction. Here we see the pectinate muscles around the right atrial vestibule, and there's a very small component of the smooth vestibule left within the left atrial vestibule. The interventricular septum is here, and you can see the rudimentary and incomplete left ventricle on the posterior inferior aspect of the specimen or the ventricular mass. The common atrioventricular valve is adherent to the crest of the ventricular septum, in effect blocking off the blood flow into this rudimentary left ventricle, so that we have a double inlet to this dominant right ventricle via a common atrioventricular valve. There are concordant atrioventricular connections, so that the musculature of this right atrium is connected to the musculature of this dominant right ventricle, and the musculature of the left atrium is connected to the ventricular mass or the musculature of the incomplete and rudimentary left ventricle.
So almost always, as you've seen, we have either double inlet left or double inlet right ventricle. But exceedingly rarely, we can find double inlet to a solitary ventricle. And this is the only true single ventricle. The ventricle itself has very coarse apical trabeculations. On occasion, it can be very difficult to distinguish whether it is a right ventricle or a left or an indeterminate ventricle. The answer is find the second chamber if you can. And if you cannot find the second chamber, then that is very good evidence that you're dealing with a true solitary ventricle. And we now know that in most instances, this is found in the setting of right isomerism, but it can be found with usual arrangement. I'm going to show you a picture of that very shortly. It also follows that since there is a solitary ventricle, the only ventricular arterial connections are either double or single outlet. So this is the nicest example I've ever seen. It is in a patient with usual atrial arrangement. There you see both atrioventricular valves entering the ventricle. The ventricle gives rise to both arterial roots, and the only septum present is the muscular outlet septum. And there you see it has remarkably coarse apical trabeculations. So this is an example with usual atrial arrangement, but much more usually we find it with right isomerism.
The apex of this specimen is pointing to the right, And we can see the arterial trunks as they exit the ventricular mass with the very dilated aorta anterior and leftward of this very narrow pulmonary trunk. Looking inside of the ventricular mass, we see very coarse trabeculations within this ventricle, which is a solitary and indeterminate ventricle. There is a common atrioventricular valve with both atriums connecting to this solitary and indeterminate ventricle. So there is a univentricular atrioventricular connection. The aorta arises here in the pulmonary trunk with a very stenotic outflow tract, both arterial trunks supported by a complete muscular infundibulum. And you can see the muscular outlet septum, which is the only ventricular septal structure in this heart. Typically, these patients have isomerism of the right atrial appendages, and if I flip the specimen up, we can see the pectinate muscles within both of those atrial appendages. So that it indeed does have isomerism of the right atrial appendages with a solitary, indeterminate ventricle.
So we've dealt with double inlet ventricle in terms of its connection. We should remember that on occasion, the valves can straddle in double inlet ventricle, either one or other of two valves or a common valve. And then we have a spectrum between univentricular and biventricular connections, and we arbitrate that spectrum by determining the proportions of the straddling valve that are committed to the complete or the incomplete ventricle. And we should remember either a right valve, a left valve, or a common valve can straddle. This is the only situation in which the connections of a straddling valve will change the type of connection that is present. But let's move on and let's look at the other variants that produce univentricular atrioventricular connection. And they are absence of one or other of the atrial connections, atrioventricular connections. And when one of these connections is absent, it follows that only one atrial chamber will be connected with the ventricular mass. And perhaps the commonest type of this is tricuspid atresia, although nowadays we know that we also find absence of the left atrioventricular connection in the setting of hypoplastic left heart syndrome. And when we have hypoplastic left heart syndrome, then the dominant ventricle is morphologically right. Very rarely we can find absence of an atrioventricular connection with a solitary ventricle, but this is truly rare. Remember, however, that we need to distinguish the hearts with absence from an atrioventricular connection from those in which one of the valves is imperfect, because this produces atrioventricular valvar atresia, but in the setting of biventricular rather than univentricular atrioventricular connections. So this is what we are going to be looking at. This is an example of tricuspid atresia. I'm showing it to you from the front. I've labeled the right atrium and the right ventricle, and you can see the big space that interposes between the cavities of the right atrium, the cavity of the right ventricle, which is incomplete and hypoplastic. So this is absence of an atrioventricular connection, but it also shows you how the cavities of the chambers can be aligned one with the other without being connected, showing that connections are not always the same thing as alignments. So to illustrate this point, now Diane will show you a very nice example of a heart with tricuspid atresia.
This specimen has classic tricuspid valve atresia with the hypoplastic right ventricle that is characteristic and the muscular ventricular septal defect. The atrial chamber can be entirely lifted off of the ventricular mass. so that this specimen has no potential for a connection between the right atrium and the right ventricle, so that the chambers are aligned, but there's no potential for a connection. When we look at a four-chamber view in a moment, that characteristic dimple that's at the base of the right atrium is where that atrium connects to the ventricular mass. That connection lies just over the cavity of the left ventricle. See if I can get a little bit closer. This is from a 20-week fetus, and here you see the morphologically right atrium, and there is no potential of connection with this hypoplastic right ventricle. So there is a fiber fatty tissue plane between the muscular floor of the right atrium and the muscular roof of the right ventricle. Where that atrium connects to the ventricular mass is here, and you can see that it is on the opposite side of the ventricular septal defect, which is in this area. There's the crest of the muscular ventricular septum. So the atrial floor actually connects over the cavity of the left ventricle. The next specimen I have has an imperfect tricuspid valve. So it too has a hypoplastic right ventricle. There is the morphologically right atrium. You can see the terminal crest and the pectinate muscles. Here is the hypoplastic morphologically right ventricle with an imperfect tricuspid valve in the inlet. There is morphologically left atrium connected to a morphologically left ventricle on the left side. So we have concordant atrioventricular connections on both sides and usual atrial arrangement. What I'd like to point out, and differing from the classic type of tricuspid valve atresia, is that we have a connection between the right atrial musculature and the musculature of the right ventricle, so that we do have a potential for a connection, even though there is a diaphragm of valve tissue across the tricuspid valve inlet. Here we're looking at a specimen from posterior to anterior, so from the spine towards the sternum, and it has hypoplastic left heart syndrome. The left ventricle has been cut in sort of a four-chamber plane, and the right ventricle has been left more intact. So here we can see the right atrium connected to the right ventricle with a tricuspid valve in its inlet. And here is our small left atrium. There's the narrow junction of the left atrial appendage with the atrial vestibule. The left ventricle is very tiny and slit-like, and you can see that there is no endocardial fibroelastosis. The muscular floor of the left atrium is not connected in any fashion to the musculature of the left ventricle. There is the circumflex coronary artery running in this fiber fatty plane that is between the atrial musculature and the ventricular mass. There is the remainder of the atrial septum, and you can see that it is aligned with the ventricular septum, so that this patient had no potential for a connection between the left atrium and the left ventricle. The chambers are aligned, but there is no potential for a connection. If we look at another heart that also has hypoplastic left heart syndrome, we see the dilated morphologically right atrium connected with this dominant right ventricle. Here's our smooth left atrial vestibule, and again a very tiny slit-like left ventricle without endocardial fibroelastosis. In this case, there was an imperforate mitral valve, so there is a potential for a connection between the left atrium and the left ventricle. The left atrial musculature is joined with the left ventricular musculature, and you can see the coronary sinus and the circumflex in the fiber fatty tissue at the left atrioventricular groove. So these chambers are aligned, but they also are connected or have a potential for a connection.
So that completes our look at the atrioventricular junctions. In our next session, we're going to talk about the ventricular arterial junctions. And what we're going to emphasize is that we have to assess independently the features of those junctions, concentrating on the connections, but remember that within those connections, the arterial relationships in ventricular morphology can vary. So this is once more where I'm going to emphasize the importance of the morphological method. But before we finish today, let me remind you what we are seeking to do with sequential segmental analysis. We're trying to build up a cascade of information. And to begin that cascade, it is essential we start with determining atrial arrangement. As we've emphasized so many times now, we do that by determining atrial morphology on the basis of the extent of the pectinate muscles, which show the extent in turn of the atrial appendage. And it is the arrangement of the appendages that determines atrial arrangement. What you have seen today is what we look at across the atrioventricular junctions. And what we're going to emphasize in our next session is what we look for when we are analyzing the ventricular arterial junctions. But we cannot move on without emphasizing one additional point, and that is the need to take note of cardiac position. But when we take note of cardiac position, we should also remember it tells us nothing about what is going on inside the heart. So that when we describe the location of the heart, we should simply say whether it is left-sided, whether it is right-sided, or whether it is in the middle. And we should then remember that the position of the apex does not always follow the position of the heart. So to take note of this, we simply say whether the apex is pointing to the right, apex is pointing to the left, or the apex also is pointing straight down or in the middle. So if I tell you the patient has a heart in the right chest, with the apex pointing to the left, you know exactly what I am talking about. So there are no problems at all if we simply describe what is going on. And it is for this reason I would commend description to you rather than trying to use somewhat jargonistic terms like dextrocardia and so on. So what I've shown you today is half of sequential segmental analysis. To repeat again, what we are trying to achieve with sequential analysis is to lay the foundation for the subsequent analysis of associated lesions. It accounts for all cases and it's suitable for everyone, and that is simply because it only depends on what you see. And we will conclude this in our next session when we look again at the final part of our analysis of ventricular arterial junctions, emphasizing again the need simply to describe what you see.
Hi, Adrian. I welcome to all the people from all over the world. So I think Adrian and you will start to summarize and make some point on this amazing presentation. Hi, Adrian. We don't hear you.
Can you hear me now?
Yes.
Perfect.
Okay.
Thank you very much. Again, a very, very good session. And Diane, you are brilliant with these hearts. And thank you, the Congenital Heart Academy, for hosting these sessions online so we can look again to them. Now, one important thing I'd like to mention, probably not that important from Professor Anderson, but important for clinicians, is that connection doesn't mean patency, because we as clinicians think of the flow of blood that goes to the heart. And as Diane showed, if we have an imperforate valve, that is a potential connection. That's not an absent connection. So that's important for clinicians, because then that puts the heart into a biventricular atrioventricular situation, even though the valve is imperforate. The distinction between alignment and connection is also very important, because we've seen that we can have the cavities aligned but not connected in situations where there is an absent connections, like in the hearts that Diane showed, in some with the Tricuspid Atresia, for example. And then I would emphasize the term atresia, because we use atresia a lot. That's an umbrella term. It's not very specific from a morphological point of view, because it covers both an absent atrioventricular connection and an imperforate valve. So atresia doesn't mean that there is a univentricular atrioventricular connection. We have to be cautious when we use it to understand its full extent. Again, extraordinary. These sessions are very important for morphologists, but they trickle down to the clinicians as well. And we'll see further and further when we look at each morphology in the future. Thank you very much.
Thank you, Adrian, for those very pertinent comments. I agree with everything that you say, and in particular, the amazing demonstrations made by Diane. It's always amazing to me. I send her the narration that I'm going to give, and I don't know what she's going to show, and it always fits so perfectly. So Diane, today you did an absolutely brilliant job, and I thought your presentations were quite superb. Norman, do you have any thoughts?
Well, Bob, yes, it was so clear that there's almost nothing to comment about. But
that's the way it should be.
What is important for me is the real difference between alignment, which I never could understand, to be quite frank and honest with you, and a connection. And I think the tricuspid atresia is just that you showed is just such a perfect example where the connection is absent, but the alignment is perfect. And I mean, alignment is just, it's so difficult for me to understand why anybody would use that when the connection is so simple. And I see that this isn't new for you, because in 1973, you were in our university and you showed this exactly, this exact situation as early as 1973. And it's stuck with me ever since, that the connection is the thing that you really need to talk about.
Well, I agree with you 100%. I mean, we have June with us again, and I know that June and I have discussed this previously, and June is not a great fan of alignments either. June, would you like to make a comment?
I always make a little bit of the too opinionated opinion sometimes, but in my opinion, that alignment should be abandoned in description of the period. Yes.
We are in 100% agreement with you there, June.
You see, but I think this is the issue here, is it's very hard to convince the populace that this is the case. And it would be nice to abandon it, but you know, you have to give them something else, and they do not abandon their old ideas, and they keep on repeating this. And that really is the problem, is the lack of vigor of thought, and just always holding on to old, outmoded concepts. And
I think
that's
for
unfortunate, but that's what we have to deal with.
Adrian, you want to make a point?
I think for septums, the concept of alignment still holds true.
Alignment and malalignment.
Yes, I think
what is important about alignment and connection is that words should give you insight into understanding.
Right.
What it is that alignment is aligned. The two chambers are aligned to be connected. That should be understood. That's why that I don't like to have the alignment as a primary terminology to describe the morphology there. Yes, aligned, but to be connected.
To be absolutely, and I agree with you, June, that we should be using words. I mean, the whole essence of communication is that we use the words to mean what they're supposed to mean, and that also is why all the time I am recommending the use now of American English rather than Latin, because the words in American English mean what they mean, and mirror imagery means what it means. It's not upside downness, but we won't go into that again.
Yeah.
So
Yeah.
I have one comment on the AV junction. So what is one missing in current description is that I have 3 cases collected. What it is that definitely there is the absent right or left AV connection, and one atrium does not connect to the underlying ventricle at all. However, one large atrium connects to 2 equally sized ventricle with a septum in the middle.
Yeah.
So the valve is straddling. Then that is actually typical double outlet left or right atrium. So in this context, what you described today, that does not have any place to go. So
you are correct, June, and I realized that at the end of the session that we should have had one more, because that, of course, is the uniatrial but biventricular connection.
correct, yes.
And we were already at nearly an hour, but you are correct. We should have included that, and that maybe we will have as we do these sessions, we realize all the time that there is more and more that we need to talk about. And I think probably we need to have a specific session on that. And maybe we can ask you to help us in that and to show us your case.
I have a very clear cases, 3 cases collected. Yes.
And we have many cases of that. I think, Adrian, you have cases in Birmingham, do you not?
I remember one, but yes.
Well, let's get a session on that.
I see there are participants who are raising their hands. Sasha, are you still with us, or have you?
I am here.
So what happens when participants have raised their hand?
It means that sometimes they make some trouble with with a Zoom meeting. No, generally is some fault. So there is a question. You already took the question about tricuspid valve atresia.
I think, what is the question? What is that question?
In tricuspid valve atresia, sometimes we get confused about absence of flow to mean absence of connection.
I think Diane has explained that perfectly, and Adrian has also explained that in the majority of cases of tricuspid atresia, it is absent connection. In a minority of cases, there is an imperforate valve, and then the connection is present, but there is no flow. So I think we should also say that on very rare occasions, you can also have double inlet left ventricle with an imperforate valve. So sometimes you can have a double inlet, a univentricular connection with one perforate, one imperforate valve, but that again is very rare. Are there other questions?
Yeah, there is one, I think, for Norman. The role of echography, fetal echography in the diagnosis of isomerism.
Well, I think that echocardiography mirrors exactly what we have seen today. If it did not, it would be absolutely useless. And so you can see the connections between the atriums and the ventricles, and all that is necessary is to describe them, as Bob has shown us so clearly, and as Diane has shown us so clearly. There's no difference between the morphology and the echocardiography. So I think it's a very easy description. I just want to make one other point, is that in my experience with educating young people, the concept of tricuspid atresia is so difficult to get across to them, because they think of tricuspid atresia as an imperforate valve. And really, tricuspid atresia is an absent connection. And this is the concept that one has to get across to the inexperienced young people, that what tricuspid atresia in general is really an absent connection and not an imperforate valve, as most of them have with an intellectual concept.
It's a good point you make there, Norman, because the case that Diane showed us today, I mean, with that is the nicest example I've ever seen with an imperfect valve, but that is so rare to see a heart like that with an imperfect valve of that size. Now, how many cases have you picked up echocardiographically with an imperfect valve?
I've got one or two
Out
in
of,
my whole collection.
Out of
in
what?
my
100?
archive.
200?
I think maybe 60 or 70.
But echocardiographically?
Yes.
You must have seen hundreds of cases echocardiographically.
Yes, what I'm saying is that I only have a handful of
Yeah.
cases where there's an absent connection. And
No,
most
just
of the
right around.
time, yes.
Imperfect.
It's in our chapter too.
Right.
Yeah.
There's one point that we should make, that Adrian and I have been discussing this during the meeting, because when I narrated my talk, I tried to emphasize, as we discussed last week, that the pectinated muscle, the pectinated wall extends to the crux in the morphologically right ventricle. And I loosely said the smooth vestibule. And Adrian pointed out that the vestibules are always smooth. What I meant to say is that the smooth vestibule is confluent with the smooth wall of the morphologically left atrium.
Right.
But hopefully people knew what I was trying to say.
I have a couple of the 4D images ready to show you. Would you like to see them? About the vestibule versus pectinate muscles?
Can you, if you can, carry on.
Okay. I will share.
Roger, can he share his screen?
Yeah, okay. Okay, so I think it works. So I will show you this way. So what I'm showing you is that you have 4-dimensional imaging. 4-dimensional is a sort of the funny word. 3-dimensional structure with one more dimension, which is time. So that is a 4D imaging. So UCLA is a frontier of this. How they do is that it's a kind of agent we use that for iron deficiency anemia, which is called the ferrohem. That stays in the body for a couple of weeks once injected. So what it means is that in MRI, it doesn't matter how long it takes because contrast medium is there. So we can do the very intensive data collection with contrast medium in the blood vessel. So that's how it is. And then I had an opportunity to review all 200 cases they have. And then I found this. So this is a regular, 3-dimensional show of the atrium. So you have atrial appendage. This is the AV valve attachment. You have a little bit of smooth part. That is what you describe as vestibule in the right atrium. In the left atrium, actually it is not definable because atrial appendage stops here and is smooth here. But that is what it is. And then the appendage is a trabeculated part or pectinated part. Okay. So here is the images. So here that you can see right ventricle and right atrium. Can you see that they serve a tubular structure just above the valve attachment? So that is what the vestibule is. Okay?
That's beautiful.
And then, yes, here in the left atrium is a smooth transition. So if you look at from below, so this is right atrium, this is right ventricle. You can see that sort of mouse into the right ventricle, having kind of, that is exactly the vestibule. What you're talking about is that pectinated part, which is atrial appendage, comes all the way down to the vestibule, all around, except the septum, right? While left atrial appendage is away. So having that concept in, so this is the right isomerism. You can see right-sided atrium and the ventricle. You see that prominent the vestibule here. So here is another, and then you can see that the other side, same thing. If you look at in short axis to look at the pectinated muscles all around the posterior wall of the lower part of the atrium. Okay. But however, what I was emphasizing last time was that is not exactly to the AV junction because vestibule is not the negligible the amount. So that is what I'm saying. So in the short axis view, another here, you can see pectinate muscles going all the way back to the posterior wall. That's the essential part. Okay. When you have a venous structure coming, it's not able to go there and it stops here. Okay. So then this is the three-dimensional, the left atrial isomerism. Okay, so that's it. That's what I want to show you. I think in the cine, you can realize that how prominent that vestibule is in usual situation. Okay.
Those images, June, are spectacular. Are those all with iron deficiency anemia?
No, it's the expensive medication. So in Canada, it is very difficult to use, but in US, in pediatric world, is a very common practice. They use the iron deficiency therapeutic agent as a contrast agent for MRI. Yes.
So you know those are. Can we get you take away your stop screen sharing again?
Sorry. I didn't get your point.
Stop screen sharing.
Yeah, okay. So they try to do it. That's what I'm doing. Okay, here you go. Oh.
There we go. Thank you.
Okay.
So were those, did you do those scans in Toronto, or are those scans from Los Angeles?
So the currently that the US institutions, couple of institutions, UCLA and the Lurie Children, where that the affiliated, and the Philadelphia and the couple of institutions they do. But however, two limitations. One is that we need to have an ethical approval to use that, and it's the really nightmare hurdling. And then we failed here in Toronto. And then the other second is that it's very expensive.
But at least, I mean, showing the pectinate muscles as you did, I hope you now agree that you can use the pectinate muscles to distinguish the appendages.
Oh, yeah.
You recall we had a little contretemps as to whether we could distinguish between the appendages and the rest of the organs. They're not always in harmony, but you can distinguish the pectinate muscles, as you've now shown so beautifully.
Oh, yeah, I agree with that, yes. Oh. So I would define that atrial appendage as a pectinated part of the atrium, period.
Absolutely, absolutely. We are in agreement.
And that refers to having a very small body for the morphologic right atrium. That's what allows the appendage to go all the way. But I think we are again behind imaging in what we said in morphology. The same thing will apply for the true single ventricle hearts, because I think with the advance of CT and with the micro CT, we have to actually see how true is that true single ventricle heart.
I think you're right there, Adrian, because if there is a tiny little left ventricle hidden in the back of it, we would see it with micro CT. But I mean, the case that Diane showed us today, I think there's little question that that was a truly coarsely trabeculated ventricle in the setting of right isomerism. And I know we have serially sectioned some hearts with right isomerism and proven that there is no second chamber present. But you are right. Imaging is now ahead of the game, but we can apply.
Actually, I really appreciated Diane's presentation last week. She clearly described and showed that vestibular anatomy, how pectinate muscles go down. Yeah, and then I think it is worthwhile to revisit that anatomy and they make it clear with the imaging and pathology specimen combined.
Correct. I agree with that.
Okay,
that in fact is the beauty of what we're doing at the moment with having the sessions where we incorporate both the basic concepts, and then Diane or Adrian and Justin will be back, I hope, next week with showing what we can do. And June, we should encourage you to contribute more from what you have.
It will be my pleasure. Honor, yes.
Okay, Bob. Thanks, everybody. Bob, you want to present the next month's appointment? So,
On the 4th of March, if all goes according to plan, I shall be with Diane in Florida. But I have to be let out of the country first, and I have to prove that I'm COVID negative, not like I am triply vaccinated. I'm not like Djokovic. So if all goes well, Diane and I will together present our final session on sequential segmental analysis, which will be on March the 4th. And then on March the 18th, we will have another session whilst I will still be in Florida. And it was a request from Grace, and she asked us if we would present on the conduction system. So on March 18th, we will present on the conduction system. And then we will be thinking of what we are going to continue as we move into April and the rest of the year. But there are so many things we need to talk about. And as we have these sessions, we find additional topics like the topic that June has mentioned today, the topic of the uniatrial and biventricular connection. Adrian and I have been discussing the things that might come out of the controversial topics we're going to be discussing in our next session in 2 weeks' time. So we will think as to how we should move forward and as we move on to the rest of the year. Although COVID is becoming less problematic, presumably, Sasha, it is your intention to continue with the Congenital Heart Academy.
yes, of course.
So we don't stop just because COVID stops.
No, no problem.
We had over 200 people joining in today, which is remarkably encouraging.
Yes.
Got the participants who are raising their hands, but I can't do anything about that, Sasha. Do they want to?
So thanks again. I hope that people will enjoy. I'm very happy. It's Bobby. We receive, I tell you every time, a lot of beautiful and surprising connection and comments from all over the world. And thanks to what you are doing is amazing. And thanks to Adrian and Diane and Norman now is.
And Tri June also. It's good to have Tri June with us now.
Yes, and now we have.
Wonderful.
Yes,
Thank
very
you.
good. The family is growing. So thank you very much.
I just hope that, I'm sorry, June makes these presentations that he can make the screen larger so that we can see the pictures more clearly.
Yes.
It's not so
I'll
easy
try.
to see them when
So
they
actually
scroll.
that's here because I need to check that here, my clinical case on the GA. So
This
Screen
first time presentation.
okay,
Some troubles. So thank you very much.
Thank you.
I will see you soon.
thank you.
Thanks.
Okay.
Thanks a lot to
Wonderful
everybody.
day.
Bye. Goodbye.
Bye.
Bye bye.
Have a nice day.